Thank you, Senator Alexander, Senator Murray, Senator Collins, my heart is still in Maine, and members of the committee. Thank you for this opportunity. I am President and CEO of the Pacific Business Group on Health. We are a nonprofit coalition of large public and private purchasers seeking to achieve higher quality and more affordable care on behalf of our employees. It is an honor to be here. This is the right discussion to be having. Thank you for your bipartisan leadership. PBGH members collectively spend over $100 billion annually purchasing health care on behalf of their employees, collectively for over 15 million Americans. Our members are deeply committed to the health and well-being of their employees and buying health care services that promote optimal health. But even the largest private purchasers of health care in the world cannot overcome the current industry consolidation, opacity, anti-competitive practices, and egregious pricing in U.S. health care. It may seem somewhat surprising that an organization representing large private sector companies would seek policy intervention into the market, and it is surprising. My members are committed to private sector market-driven solutions, but in much of U.S. healthcare, the market is simply broken. A functional market does not regularly drive families into bankruptcy. It does not depend on GoFundMe campaigns for treatment costs, and it does not absorb a decade of U.S. wage growth. If the world's largest and most sophisticated companies are challenged to buy high-quality and affordable care, it is simply unfair to expect that of small businesses or families. The dysfunction is so profound that we are seeking your support to make a functional market in the U.S. healthcare system possible, and we believe that this bill goes a long way to achieving that. There are several important points, but three that I want to highlight. There is strong evidence that cost-effective delivery, high-quality care is possible, and it should be expected. Although we prefer market solutions to the problem of high cost, government action is needed. We also support your efforts to control drug pricing, and we would urge you to go even further, and to include provisions that support primary care and mental health. Most importantly, we want to say that it is possible, and we have bold innovations driven by our employer members, most notably Walmart's recent pilots with Centers of Excellence for Specialty Services. This is a program, the Employer Center of Excellence Network, designed by Walmart, administered by PBGH and our TPA, for hip and knee replacements and surgeries. We set high-quality standards, vet and select the best facilities in the country, and support employees to use these. I've provided for your reference a recent Harvard Business Review article on the results of the program, but it is important to highlight patients who participated reported 98% satisfaction and better patient-reported outcomes. Readmission and complication rates were markedly lower. The ESIN program results demonstrate that it is possible to save money by reducing unnecessary services and improving outcomes and patient experience, while highlighting that the practices this bill seeks to address are barriers to widespread adoption of this model. Additionally, we strongly support the elements that would remove gag clauses on the sharing of price and quality information by providers. It's hard to imagine that providers are barred from sharing information about quality and cost with patients. We strongly support the elements of the bill that would ban anti-competitive contracting practices, including anti-tiering, all or nothing, and similar clauses that are used to gain market power and raise prices irregardless of quality or variable performance. We urge Congress to enable Medicare beneficiaries to identify and seek care from high-performing centers in a similar program. We also strongly support the protection of patients from out-of-network deductibles, surprise billing, and we support option 3, a benchmark for payment. We strongly recommend setting payments based on average payments to specialty physicians, i.e. 125% of Medicare rates. While it may be unusual to have us ask for price setting, we believe that this fairly captures the costs. We also think this is the most straightforward, efficient, and transparent approach to regulating these prices. A second best solution would be the use of payments based on median contracted payment rates, although we are concerned that the resulting benchmarks under this method would reflect prices that are already too high. We strongly also recommend that the definition of services in surprise billing be expanded to include ground and air ambulance services. We are pleased that you have acknowledged this as a problem, and we understand that states are limited in addressing this problem due to federal jurisdictional authority, and it is up to Congress to fix this directly. We strongly support all of the transparency initiatives, including the establishment of an all-payer claims database, but would urge you to consider complete data access, including pricing and allowed amounts, for the greatest utility of this database. We would ask that physicians and patients have key roles in the governance of such a database, and that these data sets are mutually accessible and coordinated with regional state databases. We look forward to additional questions and discussion among most of the provisions in this bill. Particularly, and finally, we strongly support everything included in the bill that would address drug pricing and would ask you to actually go further. We also strongly support the elements that would require transparent reporting from pharmacy benefit managers to plan sponsors. The lack of transparency makes it impossible for most employers to even know prices, rebates, and other pricing complexities, much less negotiate lower prices. Thank you.
Ms. Mitchell, many states, including my home state of Washington, have passed legislation to end surprise medical bills. Your organization works with large employers to bring down the cost of health care. Why is it important to your members for the federal government to act?
Well, we have multi-state employers, and it's often variation across states that really increases the challenge for them. So we need federal legislation in this area.
One of the issues that we are debating is what is the appropriate rate for an insurer to pay providers for a surprise bill. What impact do you think the proposals that we have in our discussion draft will have on enrollee premiums and access to care?
Well, our experience in California is that it has no effect on premiums. We actually believe that we can achieve very fair pricing at 125% of Medicare. Evidence shows that 25% of hospitals are actually succeeding under Medicare rates. We think that there are significant opportunities for business practice improvement and increased efficiency among hospitals, but we believe that that is a fair rate and could be sustained.
Okay, thank you.
Ms. Mitchell, you've dedicated a substantial portion of your career toward promoting more transparency in healthcare pricing as well as higher quality. And as a result, today, the state of Maine is one of the best states where you have all payer claims database. I've joined Senators Rick Scott and Cory Gardner in introducing a bill that would create a consumer-friendly database for prescription drug prices. In your written testimony, you talked about two powerful examples of an employer who was overpaying for prescription drugs. One was a kidney patient where the employer cost was $138,000 every 2 weeks. It now looks like it's going to go down to $26,000. The other was a pediatric patient. The cost for the employer was $750,000, and now using a different hospital, that cost may be only a third of that amount. So what led to those success stories? Was it greater transparency? Was someone negotiating for the employer? What produced those kinds of results?
Thank you, Senator Collins, and I think those are important examples of both the problems in the system and also the opportunities to fix them. These cases could not have been addressed without transparent pricing information, and only these very large employers can have access to that information oftentimes. We believe that with greater transparency, more actors, more employers, more insurers would identify solutions like this. And I wanted to point out that, particularly in the case of the pediatric patient, those annual costs of $750,000 were brought down to $250,000 a year, same drug, and they were administered at home at the request of the family. So this was a win-win for the employer and for the patient. We believe that transparency would enable more success stories like that.
Biologics are one of the categories of drugs that are most expensive. The Aging Committee, which I chair, has had a number of hearings on this issue, and what we found is that the brand name manufacturer often puts up patent thickets that prevent biosimilars from coming to the market. By contrast, the biosimilar uptake in Europe is much more prevalent than in the United States. In fact, the former FDA Commissioner Scott Gottlieb has estimated that if all the biosimilars that have been approved by FDA actually made it to market in a timely fashion, that American consumers would save more than $4.5 billion. Do you have any thoughts, and do you support the provisions in our bill that attempts to prevent the gaming of the patent system to delay the advent of biosimilars to the marketplace?
Absolutely. We strongly support any of the changes that will enable increased access to biosimilars and anything that prevents. We believe that there needs to be strong action on drug pricing, and we strongly support your provisions.
Thank you.
Do you think the consumer, the employee, has atrophied to where if we do make it more transparent and we get the industry to ever get out of its doldrums, will we have employees, consumers, patients be willing to have some skin in the game and help the system out as well?
Absolutely, and I think patients and families absolutely have skin in the game, the health of their families. But they are in a completely untenable, unfair situation. They have no information. We're talking about providers not even being allowed to share information with them, the providers that they trust. And we ask them to be responsible consumers with no ability to do so, no cost information, no relative quality information. So our members, and you would always be welcome as an honorary member, our members are trying any innovative approach they can to actually work with their employees to address their concerns. So we absolutely believe transparency is necessary and that we will have active involvement of patients.
Can you discuss how more data on drug pricing decisions and expenditures will help policymakers, researchers, and other industry stakeholders make better healthcare decisions?
The problem is the pricing. And everything we're talking about, rebates, that's just obscuring the actual issue here, which is the pricing. Our members are trying to offer discounts. They're basing those on estimates because they can't get insight into the actual price of the drug. So we absolutely need transparency, but it's just the starting point.
Mr. Kavanaugh, you indicated that one of the challenges with benchmarking is that you have a huge network of people that are responsible for setting Medicare rates, but that something of that nature doesn't exist if we were to put in place a benchmark system. On the other hand, Ms. Mitchell indicated that she would set the benchmark based upon the Medicare rates. So would that not remove the complication that you're concerned about, which is to simply set a benchmark rate and do it based upon either 1.25 times the Medicare rate or 1.5 times or equal to, but basically use that as the benchmark figure? Would that remove that complexity you were concerned about?
Sure. Thank you, Senator. The only point I was trying to make is in Medicare Advantage, there is a benchmark rate that operates this way, but it's publicly known. Like, I can go online and tell you today what the benchmark rate is in every community for every service. This legislation, one of the options would create a new benchmark rate with a different methodology, and someone's going to have to go and build that and figure out what those rates are. I didn't mean to make any bigger point than that.
Yeah, thank you. So, Ms. Mitchell, do you have any comment on that?
Again, we think that this is the most straightforward, efficient, and transparent way to come up with fair rates, and the evidence supports the rate. Actually, 25% of U.S. hospitals manage their cost well enough that they are successful under Medicare rates. And we're not talking yet about costs. The recent report by RAND shows that hospitals bill commercial payers and employers an average of 240% of Medicare. So what is the actual cost to provide that care, and how do we agree on a common standard? We believe that 125% is fair.
I have kind of a two-part question. What else do you think is effective to get a telemedicine program up and running? And what do you think the minimum time length or a time span would be reasonable for a telemedicine program, especially once we get some templates done?
If I may, Senator Collins graciously shared that I am from Maine. Much of Maine is also frontier, and I worked closely with many rural hospitals in the state. we are very sensitive to the pressures on those hospitals. They are very real. And we hear hospital and physician executives saying they have to charge inflated prices to subsidize the care that we aren't appropriately paying for, like maternity care or primary care. So I agree that we need to look at direct ways to subsidize that care. And we need to be thinking about rural patients instead of just rural hospitals. I also was extremely encouraged in my time on the Physician-Focused Payment Model Technical Advisory Committee. There were innovative proposals like hospital at home that were supported by physicians, new ways to deliver care to rural patients that needed hospital-level treatment. So telemedicine, hospital at home, these innovations are absolutely essential to bringing care to those communities.
Would the American Hospital Association be willing to publish in understandable form charge masters across all hospitals, and in talking to a lot of people that really know what makes the current system not work, would you be willing to expose third-party arrangements between providers and health insurance companies, which so many people have told me if that ever happened, it would break the system and you'd cascade into transparency and competition. And I know that's a load, but give me your quick comment on it, please.
I hope I can remember all that. So first of all,
Charge master first.
Charge master, I know, is a daunting experience. John can probably speak to it from CMS. We have worked with CMS to publicize more and more of the charge master, but I agree with you. I don't think that's data that people need. I mean, something that gives people prices to the degree that we can do it, to the degree that we can make that simple enough for people to understand. I think that's the way that we should go. We would definitely.
It's mandatory that you find out how to do it. Now, what about the third-party agreements
that
between providers and insurance companies, which blew the whole system with opaqueness? Go ahead.
I mean, that we would disagree with.
I figured you would. I just wanted it on.
I'm certainly predictable.
Yeah.
No, and we've raised concerns. I know the administration has discussed that. The ability for two parties to have private contractual negotiations is important. And I think even the Federal Trade Commission, which has never been the biggest.
In a robust, competitive market, I'd agree with you. In a broken system like yours, you ought to get with it. Ms. Mitchell, what do you think? You've been wrestling with this kind of stuff. Do you see the industry, especially hospitals, 30% of the health care bill, kind of resisting right there in terms of what they think? Do you think there's any chance that the industry will start coming around to where we don't have to legislate them into action?
Well, one can hope. I would say that if these secret negotiations between providers and plans worked, we would not be sitting here. I think everyone in America deserves insight and information about their medical care, the quality, the outcomes, and the cost. We are all in this together. We all have skin in the game. We need a system that is responsive to the American people, that requires and presumes transparency and accountability.
Agree 100%. Thank you.
One question, Ms. Mitchell, and then we'll wrap up. The bill that Senator Murray and I proposed requires pharmacy benefit managers to give employers information on the rebates in the system so employers understand what they're paying for. So if a pharmacy benefit manager negotiated a $400 discount and let's say a $600 insulin price, the employer would know that instead of $600, the price is $200. Mm-hmm. How will we know that the employer will pass that $400 discount on to the patient who has diabetes?
No, I think it's an important question, and many of our members are doing this now. They are offering and extending the rebates to their employees, but as I said earlier, they don't have the actual cost and price information, so they're using the estimates. The problems with spread pricing and rebates off wildly inflated prices make this more complex and convoluted. So they are looking for ways to decrease these costs for their employees, and transparent, clear pricing is part of that.